All right, let's get right into it. Today, we are taking a deep dive into your circulatory system. We're going to explore the incredible and sometimes incredibly dangerous world of blood clotting and the amazing drugs we've designed to control it. So, it really all starts with this one central question. I mean, think about it. Our blood's ability to clot is a brilliant defense mechanism, right? It's what stops a paper cut from becoming a disaster. But that same process, in the wrong place, at the wrong time, it can be absolutely deadly. And this really shows you the two faces of clotting, doesn't it? A good clot, that's your body's emergency medic, sealing a wound, kicking off the healing. But a bad clot, what we call a thrombus, that's a whole different story. It's a rogue agent. It can block blood flow to your brain and cause a stroke, or it could travel to your lungs and cause a pulmonary embolism. So how does the body even manage this high-stakes process? Well, it happens through something called the clotting cascade. And let me tell you, it is one of the most elegant and lightning-fast emergency response systems in all of biology. Just think of it happening in 3 super-fast stages. First, bam! The injured blood vessel squeezes itself shut to limit the bleeding. Then, these tiny cell fragments called platelets swarm the area, clumping together to make a quick, temporary plug. But you know, that plug is kind of flimsy, so the body kicks off step 3, building a really strong, reinforcing net made out of a protein called fibrin. And that final step, building the net, is all driven by the coagulation cascade. The best way to picture it is like a complex, perfectly timed set of dominoes. Specialized proteins called clotting factors trigger each other, one by one, until you get that final, super stable clot at the end of the line. And what's really interesting is that this domino rally can actually get started in 2 different ways. You've got the intrinsic pathway, which kicks off when there's damage inside the blood vessel. And then there's the extrinsic pathway, which gets triggered by trauma outside the vessel, like a big injury. They use a few different dominoes, a few different factors, but their ultimate goal is exactly the same. Because here's the critical part. Both of those starting paths eventually merge at one single point. And that is the activation of a protein called Factor X. You got to think of Factor X as the star player here. It's the point where everything comes together to set off the final and most important step of the whole show. And what is that final step? It's creating this guy, thrombin. So if Factor X is the star player, thrombin is the master builder. Its only job is to grab a protein floating around in your blood, called fibrinogen, and convert it into these long, sticky fibrin threads. And those threads are what weave together to form that tough, durable mesh that makes a blood clot so strong. Okay, so if that's how a clot forms, how in the world do we stop it when it's going haywire? Well, we use a class of drugs called anticoagulants, or as we're calling them, the clot busters. Let's meet the tools that can tame this cascade. Medically speaking, we've got 3 main types of tools in our toolkit. There are the classic vitamin K antagonists, or VKAs. Then you have the super fast-acting heparins. And finally, the modern precision-targeted drugs called direct oral anticoagulants, or DOACs. And each one messes with the cascade in a totally unique way. So let's start with the classic, Warfarin. It's a vitamin K antagonist. Now, it doesn't attack the clotting factors that are already floating around in your blood. No, it goes right to the source, your liver, which is the factory that makes a bunch of these factors. Warfarin basically just slows down the factory's production line, which means there are fewer of those key factors available to build a clot in the first place. And it is incredibly effective. It's been a workhorse for decades for stuff like atrial fibrillation or in people with mechanical heart valves. But the big challenge? That factory slowdown is kind of hard to predict. And that means patients need frequent blood tests to make sure their blood isn't getting too thin or not thin enough. And of course, like with all these drugs, the number one risk is bleeding. Next up, we've got heparins, and these work in a really clever way. They don't block anything themselves. Instead, they find a natural clot-fighting protein that's already in your body called antithrombin, and they basically supercharge it. They give it a massive boost. And this newly empowered antithrombin just goes on a rampage, rapidly taking out both the master builder, thrombin, and the star player, Factor X. Because it works so ridiculously fast, heparin is an absolute go-to drug in an emergency, like a heart attack or a big pulmonary embolism. The main downside is it has to be given by an injection or an IV. And while bleeding is always a risk, it also has this very unique and serious potential side effect where the body's own immune system starts attacking platelets. That's a condition called HIT. And that brings us to the newest tools in the box, the DOACs. You can think of these as the snipers of the anticoagulant world. Instead of slowing down a whole factory or boosting a helper protein, they act like a specific key made for a single lock. They go straight to one critical factor in the cascade and just shut it down directly. Now, DOACs themselves break down into two main groups, and it's all about what they target. You have drugs like Apixaban and Rivaroxaban. These are factor XA inhibitors. They stop the star player before it can even create the master builder. And then you have Dabigatran, which is a direct thrombin inhibitor. It lets the master builder get made, but then it swoops in and blocks it from actually doing its job. See, two different precision tactics, same result. So why are these drugs so popular now? Well, the huge advantage is just how convenient and predictable they are. For most people, you don't need those constant blood tests, and there are way fewer interactions with food. They're used for a lot of the same reasons as warfarin, but, and this is important, even with all the convenience, they're still very powerful drugs, and bleeding is always the #1 concern. So you can see that at the end of the day, managing blood clotting is just an incredibly delicate balancing act. You're trying to turn down the clotting system just enough to prevent a disaster, but not so much that you cause a completely different one. And this chart just sums it all up one last time. You've got warfarin, the factory slowdown, which is a great tool but needs that constant monitoring. You have the heparins, the superchargers, which are incredibly fast but have some unique risks. And then the DOACs, the direct blockers, which are super convenient, but that risk of bleeding, it's always there. And this really gets to the heart of it all. We never, ever want to completely stop the body's ability to clot. I mean, that would be just as dangerous. The entire goal here is to find that perfect sweet spot, to just turn the volume down on the coagulation cascade enough to get through the danger zone, which leaves us with a really interesting question for the future. As our understanding gets deeper and our arsenal of these clotbusters keeps growing, the challenge really starts to shift. It's not just about having a tool anymore. It's about picking the absolute perfect tool for each and every individual patient. And that, right there, is the next frontier in taming your blood.